Hi everyone, welcome. I'm so thrilled to introduce Dr. Lyris Schonholz. She's going to be talking to us today about why to have a pelvic ultrasound. Dr. Schonholz is a board-certified radiologist specializing in diagnostic and screening ultrasound. Her focus is diagnosing cancers in their earliest stages, specializing in abdominal and pelvic ultrasound screening for asymptomatic men and women. Today, she's going to talk about her work and the process of screening women with gynecologic cancer. Dr. Schonholz, thank you so much for joining us. The floor, the camera is yours.
Okay. It's interesting, the topic. I think when I listened to what the topic was, my response would be, why not have a pelvic ultrasound? And that's really where I'm coming from. My passion has always been to try and find cancers in their earliest stages. And one of the issues that has saddened me and is just a difficult situation is when I do have a patient come to the practice who already has a symptom. And sometimes that symptom has been going on for some time, sometimes less of a time. And typically when I'm diagnosing a cancer and the patient has had symptoms, we are not dealing typically ever with a stage 1. Occasionally it's stage 2. But more frequently a stage 3 or 4. So my goal is to get people to screen. I'm going to concentrate on pelvic and abdominal screening. We'll talk about that, both of them together, because basically we've sort of accepted that there's screening that we need to be doing to catch cancers early. And that's, I think everybody knows, we want to go have skin checks annually, sometimes biannually, based on whatever the person's, they're redheaded, or if they have a mutation or a family history. And we accept that. And we accept that there needs to be breast cancer screening, we accept colon cancer screening, and we accept prostate cancer screening. And still, it seems that for some reason, probably because the numbers aren't so great, that we just have decided not to look at ovaries and not to look at the uterus and not to look at the pancreas and not to look at the kidneys and not to look at the bladder. And we can talk about benign disease as well, that there's some very interesting and very important things to pick up as well that are not malignant, but today our focus is picking up early cancers. So that's my passion. My passion is try and get as many people in as possible, men and women, to look at these organs that people aren't looking at. And the goal of that is to find these early cancers. We can't find everybody's cancer early. It depends on obviously what the cell is doing, how long it's been in the body. Some people will have more advanced disease and ironically be asymptomatic, though I find in my many years of practicing that's not common, but I've seen it. But more commonly, what I'm picking up is people who feel fine, who are coming in and hoping to be told they are fine. And I also think that's a great reason to screen, is to tell people they're fine so they can walk out with some peace of mind that they are okay. But the goal is to find these early cancers, these stage 1 cancers that are sitting there and no one's paying attention to them because the patient feels fine and may even be told you don't need to do anything because yeah, you feel okay and your blood work's okay and don't, it's not necessary. Are there false positives on any kind of screening test? Are there false positives on blood tests? Absolutely. The more skilled the observer, the less those come into play. Certainly people can always get second opinion based on a reading. If there is a reading that's significant requiring surgery, there can be obviously a second opinion. There can be even a different modality that's done if need be to ensure that the sonogram has been interpreted properly. It is a very operator dependent test. Unlike MR or CT, you do need the human to create the image with the machine versus CT or MRI imaging. You need a great machine, you need the proper protocol plugged in, and then you need the person to obviously look at the images properly and interpret them properly. It's an easy test. I would say it's relatively non-invasive in the sense that there's no IV contrast necessary, there's no radiation, and it's a fairly short test as well. Years ago for the pelvic, you needed the bladder very full. I like the bladder be filled a little bit so we can do the bladder cancer screening. It doesn't take much. The vaginal sonogram should be relatively brief, I tell patients. It should not be a prolonged process. And the images are extremely exact and they're very specific. And that's one of the issues I think that maybe is out there, that there's not quite an understanding of how specific the imaging is. Pancreatic cancer imaging is something I'm also very passionate about. Sometimes if a practice will send out a report stating the pancreas is obscured by bile gas, it's not uncommon for an excellent doctor to get a few of those to realize that maybe you just can't see the pancreas. It's just always gassed out, and it's an easy thing to overcome just by having someone drink a bottle of Poland spring water. And sound, we know, loves to go through water. We know that from dolphins and whales and sonar subs, and we know sound does not like to go through air well. We know that from hearing aids. So if you have someone drink some water, then these sound waves just go through the stomach and the pancreas sits behind the stomach. And it's just, it may take a little longer, it may take 10, 12, 15 minutes to add to a test, but that's what you have to do. So you have to make sure that the test is always done properly. I am also not just passionate about screening pelvic ultrasounds and abdominal. I am pretty passionate these days about educating women about the papillary serous cancers that come from the end of the fallopian tubes. I think we were all taught in early bio classes in grade school that the very end of the fallopian tube, which are the fimbria, the little finger-like projections that would grab the egg when it comes out of the ovary. We've now learned that some of the most aggressive forms of ovarian cancer come from, and they're microscopic cells. So a sonogram is a picture, an MR is a picture, a CAT scan's in a picture. We're not microscopes, not using microscopes. Those cells can drop onto the ovary, which is been described as very rich soil. And if those cells drop on there, they can form a very aggressive cancer. I found stage 1s in people. And how did I find those kinds of cancers? They are totally asymptomatic. Some have been larger than others. Some have been very small. And these people have done extremely, extremely well. They're not presenting with advanced, stage 3 and 4 disease. But I am very pro and advocate of getting educated and also learning about having fallopian tubes out. Obviously, there's situations where someone might be at risk to have surgery prophylactically, may not want to have surgery prophylactically. Surgery is still surgery. But if I'm very, very involved in educating my patients in I prefer not to see a stage 1. How do we try and avoid that? And some of that is with prophylactic surgery, which I think is important to get out into the community to understand that better. That said, what am I dealing with? I'm dealing with patients who have not had prophylactic surgery, and my job is to try and find cancers in the fallopian tubes, and that's a different kind of cancer, what actually forms in the tube, versus finding ones that drop from the tube onto the ovary and then present as ovarian, or form in the ovary themselves, and also obviously in the uterus. And I'm particularly interested in finding uterine polyps. Can't always tell by the sonogram if they're benign or not. I'm quite pro having polyps removed if they're seen, to have a microscopic diagnosis. And again, very, very passionate about picking up early kidney cancers, which thankfully many times are very slow growing. So it's tragic when someone comes in with more advanced disease from that case. All cancers have adjectives on the pathology report to tell how aggressive was that cancer. And I think the cases that resonate with me particularly are when people come in with symptoms with a stage 4, and I find out on the path report it was a more slow growing cancer, where if they had been screened annually, they would have had a much better chance of having their disease caught earlier. So that's my passion, is getting that word out that actually ultrasound can find these cancers early. I'm sure there will be many better things coming down the pike at some point, DNA molecular testing, blood tests, et cetera. But this is what we have right now. And it's a great modality, and I don't think it's being used to the extent that it needs to be used to. And that's the purpose for this talk today. If anybody has any more questions, I'd be more than happy to answer them.
Thank you. Do you want to, I had sent you over some questions that people had asked just in terms of when to start. Do you want me to read those to you, or do you have them available? I'll just double check.
You can read that. As far as starting, it's a really interesting question. I think if someone has no family history whatsoever, if they do not have a genetic mutation, but I want to speak about that again in a little minute, then I would say, and this is an arbitrary number, For pelvic screening, I would say for pelvic and abdominal screening for women, because the women have the abdomen done at the exact same time that they're on the table, I would say 30 and up. For men, I would advise 40 and up for abdominal screening for starting to look at somebody's pancreas and kidneys. So I'd say age 30 for a woman and age 40 for man. I would totally change that based on if there was a significant family history or if there was a pathogenic mutation in the family. People who have family histories and they come on in and they tell me that, oh, we're BRCA negative is usually what they say. And usually the first thing I say is there's a number of mutations. That's one of them. So I always want to know, did they have a more complete panel done? And even if they're negative, I say, negative is great. We love to hear the results are negative. But negative, unfortunately, also could mean there's a pathogenic mutation in the family, and that could be a family without a history or a family with a family history of cancer. And that mutation has not been discovered by science yet. So there gets to be this false sense of security that we have cancer in the family or we don't have cancer in the family. And I went and did screening and we have cancer in the family, but we don't have that gene. And you don't have the mutation that's known by science in 2022. The question is what will be known by science moving forward. I don't want a false negative test to dissuade people from screening. And here's the other situation. It doesn't have to be a false negative. It could be a true negative. Maybe the family has no mutation that's been passed on and other causes have, caused a cancer to happen, or a spontaneous mutation has caused a cell to go rogue. But I would say 30 and up. I would give a much different answer if there was a pathogenic mutation. I would start much younger in the 20s, probably mid 20s. I've seen ovarian cancer in the 20s. It's not common. I have patients who have had it, but statistically the patients are older than that.
And how often should someone with a history of gynecologic cancer have a pelvic ultrasound?
That was a really interesting question. So first I'd say I believe everyone should have one annually at the age that we talked about. And then I see many patients biannually who have either a pathogenic mutation or have a strong family history and they are mutation negative, but they're concerned there's a mutation in the family that hasn't been discovered. As far as people who have had cancer already, what I would say, people who have had hysterectomies and oophorectomies, there's other organs in the body. And I think it creates great peace of mind to know that you're looking at other organs, to making sure that nothing else is going to happen that couldn't be caught earlier or in time, hopefully. And so I would say to those patients, even if organs and various structures have been removed, there's still other things in the body that we can screen for. So I would suggest, depending again on their past history, what they've had, family history, I would at least do it annually for sure. There's occasions when I've picked up recurrence where the disease is very slow growing, the cells are not that aggressive. So a PET may not have seen them because the activity of the cells are not active. And that's happened as well. But I really do feel strongly about PET imaging and MRI imaging and CT imaging as a way also to screen people who have had disease. I think it's really a holistic approach. There's blood work that's done, and that really is based on what the oncologist wants. I have had some recurrences of people who have had endometrial cancer when I think it's easy enough to do a vaginal sonogram and always look to see where the uterus had been and are cells not accumulating there. It's an easy test to do. So from my mind, I think it also gives people great peace of mind to be screened after they've had a cancer. And I think it's an easy way to screen people also when they've been released by a gynecologist or a GYN oncologist to say, okay, you're okay. We're done now. We don't need any PET CTs or CTs anymore. And there's a sense of a bit of a sense of fear, I think, when you've been, let go. And my feeling again would be to say there's still other organs in there. So why aren't we looking at those as well?
Okay. Someone asked if they need a referral I'm not sure if it was to you or to just in general to have a pelvic ultrasound. Could you answer that?
Absolutely. Since we are specialists and we're not primary care physicians, we always require a referral or prescription. And that's for a few reasons. One, in our practice, we talk with the patients immediately with the results. Ultrasound results are immediate. As soon as the person's doing the procedure, you know the answer to what's going on. And we also want to have the conversation immediately with a physician who is responsible for the patient. So what we don't want to ever have happen is somebody comes and self-refers, which we won't allow. And then you have to start to scramble to try and, get somebody care, or who's the person that we have to speak to, or, oh, that person just retired. And then you have, nobody to speak to. So it always is required that somebody order the test. It can't be, I do feel it's very important for patients to advocate for themselves, to get screening or to get a follow-up if it makes them feel more comfortable. But in the end, it must be ordered by a physician, primary care physician of sorts, GYN oncologist, internist.
And Cynthia's asking if insurance covers it.
That's a really good question. I think everybody's insurance is different. And I think the sad answer, Cynthia, is no. Particularly if someone feels well, particularly if that person doesn't have a family history, has no gene mutation, a pathogenic mutation. And I think that's the tragedy, because certainly insurance, I'd love to say that they cover everything they need to cover when someone's undergoing treatment. I certainly am aware of people that I know who have gone to Facebook and raised money for bone marrow transplants and things along those natures when they have not been able to get complete coverage from an insurance company. So for me, I think it's unfortunate that insurance companies are not covering screening, which is when we would be catching disease potentially at its earliest. So I think it's up to everybody's individual company, but my understanding is that they're not providing coverage for many of these screenings, but there are companies that do. For sure.
And I also would like to just remind everybody that if a screening is something that's recommended by your doctor, but your insurance is not covering, Woman does have the financial assistance available to help with that. That's a conversation just to have with Carly or myself or your oncology social worker.
Besides, just the personal aspect of having to deal with a cancer that needs treatment, and then worried about, is my insurance company going to cover it? And the cost of that to the company. Whereas if you were catching things early, that's the most important thing, right? This is not a financial issue. It's that you want to save somebody's life. So that's the issue with screening. But then compound that with the cost of catching something late and what people have to go through and suffer through, for that journey to be cured. And the cost of the insurance company to have to deal with that, it would be much easier, much better for people to be have their cancers caught early. The financial part, I think, is just unfortunate to have to talk about, but to have an extreme cost later and to have that added on top of the hardship emotionally and physically that somebody's going through, it would have been much easier to catch some of these illnesses in a stage 1. You can't catch everybody's illness in a stage 1. I said that, it's based on the individual disease, it's based on what the cell is doing. But the tragedy is, if you're not going to look at asymptomatic people, you're not going to catch it early.
Someone asked, how do you assist your patients with genetic mutations through pelvic ultrasounds? And does that change based upon the mutation, such as BRCA or Lynch syndrome?
I'm not sure what they're getting at. So as far as if somebody has a pathogenic mutation and a patient comes to the practice, absolutely, we see them more than once a year. So we see them sometimes twice a year. Sometimes we'll see them more than that. And sometimes the patient asks to be seen more frequently. My goal is to make people feel comfortable, but my other goal is to catch aggressive cancers as early as possible. So obviously, if somebody's going to have a slow growing cancer, looking once a year may actually be fine. If they're going to have an aggressive cancer, we don't have a crystal ball. The more you bring them in, the more likely that you may catch something if something develops. You definitely tweak having somebody come in based on whether or not they have a pathogenic mutation, such as a Lynch, or, if they have a BRCA mutation or any other mutation. We encourage patients to get genetic testing, though I also encourage patients to not get a genetic test unless they can handle hearing they're positive. I think they have to go into a testing situation trying to predict emotionally if they can handle a positive result. I've had too many patients come to me who have had genetic testing. Their feeling was, from what they recall, it wasn't explained in a way to them that they totally understood what they were looking for. They came back with a pathogenic mutation, and some people were really undone by that, to a point that those people would have, in retrospect, preferred to have screened but never known. They said I would have, done the screening, but I didn't want to know. And it's hard sometimes for people to wrap their heads around a statistic to be told a person has an increased incidence of something, but it doesn't mean it's going to happen to them. So I'm very pro screening, but I'm very pro that the patient has to understand that I want you to assume that we will discover a pathogenic mutation. Is that something that you'll be able to handle? And I think it's important. And obviously with pathogenic mutations, depending on what the mutation is and what the risk is, I explained I'm very pro prophylactic surgery to try and prevent disease. Sonograms aren't preventing disease, CT is not preventing disease, neither is MR or PET CTs. What they're trying to do is catch disease as early as possible, which is very different than preventing it. My goal is to catch it as early as possible. The best chance I have is seeing asymptomatic people.
Someone wrote, I have ovarian cancer. Should my daughters get pelvic ultrasounds? They do not have the BRCA gene.
If this is somebody who does not have the BRCA mutation, a pathogenic mutation themselves, and they have children, this is another thing I also find that it's really important to educate men and women that these mutations are in both men and women. So if that person also had a son, there would be talk about screening that individual as well later on in life as well, for prostate, breast imaging, melanoma imaging, depending on what the mutation is. So in this case, the person's saying, I have two children who are daughters who don't have a mutation. If the mother had a mutation, that is when you have a true negative, right? Because then the children did not get the mutation, I'm assuming in this, and that's the best case scenario for offspring, is that they did not get a pathogenic mutation. Would I still screen those girls at 30 and up? Yes, I would, because people who don't have mutations still get cancer, of course. And I think she's probably asking, saying, I don't have a mutation, I have two daughters, what do I do? Because I think people just generally should start doing this at 30, I would say to her this: the family may have a mutation in the family that hasn't been discovered, a pathogenic one, they may not. I would at least have her daughters start at 30 and up, if not a little bit sooner. And depending on just talking it out with the daughters, they might feel more comfortable coming in twice a year with a parent who's already had ovarian. They may feel, I want to look more carefully. I want to be more on top of it. So I'd say at least annually, but I'm saying that to anybody who doesn't have a family history.
Okay. And so anyone, I'm just thinking a little bit out loud. So of course you said anyone who has a family history, anyone without a family history should be screened at 30. But if they do have a family history, does that change in terms of even seeing earlier, would you suggest?
Absolutely. With a pathogenic mutation, no question. And in a case like, I think what's being described, ovarian cancer, two daughters, if they're already 30, it's time, it's past time. And if they're younger than 30, you don't want to create anxiety by screening too early, too young. Sometimes it creates anxiety. Other times it makes people feel more in control. Let me see what's going on there. And again, that would be sort of a case-by-case situation.
Someone wrote, I have as a radiologist, you speak with my oncologist after reviewing my ultrasound.
Oh, always. I mean, as I said, our practice is a little unusual. This may not be in every practice. That we tell the patients immediately what's going on. That may be a bit unusual. In my practice, I do the pelvic ultrasounds. I'm not a tech, but a physician does. And that said, the diagnosis or what we need to discuss is discussed with the patient and then is immediately discussed with the doctor, of course. Yeah. And when we
and you said because as you're a physician, you tell the patient after the pelvic exam because you are a physician.
Yeah, and patients want to know, and most patients do understand now with ultrasound in particular, the results are there on the screen. MR, there's many images that have to be studied. CT, there's many images that have to be studied. That's not the case with ultrasound. Ultrasound, the image is created, and as soon as you look at the image, you have an understanding of what it is. There's not a delay in looking at the images later, is my point.
Someone wrote, I've had one recurrence of ovarian cancer. How often should I get an ultrasound?
Again, that would be a question where I would totally ask their oncologist. I wouldn't feel comfortable answering that kind of question. So it depends, what stage were they in, how far along, was their disease initially? Are they being tracked by, CA-125s? Was that elevated at the time of their diagnosis? That's really a question, for the oncologist. Would I like to see that patient once a year? Of course I would. They have other organs going on in there, and I would love to be checking those out for them, sure.
Another question. Sorry, I'm just between the screens.
Can
an ultrasound be, oh, go ahead.
Yeah, it's an easy test. That's the other part of it. It's a relatively easy test. I think it's relatively uncomfortable, relatively. It's a quick test. The answer is immediate. And there's not that many, and the findings are very, very specific. They are not vague. It's just not difficult to diagnose significant issues, be it benign or malignant for that matter.
Someone asked, could an ultrasound be used in lieu of another scan?
It's a really good question. I think it depends on the comfort level of the ordering physician. I think a lot of people are very comfortable with MRI imaging for the pancreas. They're also very comfortable with something called an endoscopic ultrasound, which is done with a probe that goes down into the esophagus and the stomach. Ironically, it's using ultrasound waves. So there may be some talk with a referring physician about advocating for having a sonogram done for screening for the pancreas, just because there just may not be the fund of knowledge based on, other reports they may have received saying that it was obscured by bile gas. And as far as imaging, I think many times there's a number of images that are done that with MR and CT in concert with one another. I do feel the most specific imaging of the ovaries, no question, is ultrasound. Never a CT, not for stage ones. I don't feel particularly that MR is either the way for screening for picking up early ovarians. I think right now the most specific way to find I'm talking about something very small and subtle, is with ultrasound screening. Something larger, it would be different. And size, by the way, doesn't mean that something's terribly aggressive. You can have a very slow growing cancer that's large, and you can have a very tiny cancer that's extremely aggressive.
So someone goes oh, go ahead.
For finding really small things, I would say ultrasound for the ovaries, no question. Yeah.
So someone wrote something very similar, but it sounds like the answer would probably be no. So they wrote, does it make sense to switch to ultrasound in lieu of MRI going forward for screening? My insurance left me with a big bill for the MRI. And it sounds like it depends on what you said in terms of the size, but if it's just because of the bill, that's not the reason to change.
It depends on what they're talking about. So for MRI imaging of the pancreas, for instance, that's considered standard of care. And I'm very, very pro people getting screening MRIs when we're dealing with people with family histories of pancreas, or we're dealing with pathogenic mutations that increase the risk of pancreatic cancer. I still love to see these patients twice a year with an ultrasound. We've had a few cases in our practice where the sonogram picked up a very, very small tumor that needed to be excised, and an MRI just wasn't able to see it, and a CT was not able to see it, because we're talking about very small things under a centimeter. Those people ended up having a biopsy with an endoscopic ultrasound, and they ended up having surgery, particularly these small neuroendocrine tumors, which was the type that Steve Jobs had. And I have 12 women who had surgery, no chemo, no treatment after that, and they were all cured at surgery. And 2 of the cases were so small they weren't seen. Once the sonogram is positive, you typically send for the MRI, called MRCP of the pancreas, and they were too small to be seen. So they went and still had the biopsy, the endoscopic ultrasound, which is how the biopsy is done. So I do like for these really, really small lesions to still do the ultrasound, but I am a proponent of everybody getting in there together and discussing what's best for the patient and how best to screen. And I do like screening MRI and an endoscopic ultrasound for the pancreas as well. I think it's very important.
What about a transvaginal ultrasound? Do you do those in conjunction with a regular pelvic ultrasound?
Always, one should never have just a trans-abdominal ultrasound of the pelvis, and one should never have a transvaginal done alone either, because there's some cases where an ovary may sit up higher or something else sits up higher. So vaginals are great at seeing things low down in great detail. I tell people, if you went to a museum and you put your face against a painting and you go, well, it's a painting. And then, but you can't really see that much about it, particularly with larger things. You have to step back to get that perspective. So the vaginal, ironically, could miss a very large ovarian tumor sitting higher up in the pelvis. It's just not going to see it. It's going to see things close down where the probe is, but it's not going to see things further away, higher up in the pelvis that can be very large. So you always want to have the imaging done on the outside of the body, and also done with an empty bladder at that point with the vaginal sonogram. So there's not a single patient in our practice who doesn't get a vaginal sonogram unless for some reason they can't have one. They always should be done. I do find where I fine tune the stage 1s are on the vaginal sonogram. That's where you're going to see these really early ovarian cancers, these really small cancers, either ones coming from the fallopian tube or starting within the ovary. They're going to be on the vaginal. That's where you're going to get the real specific information. It's not that you can't see them from the outside, but the smaller the cancer with an ovary, the more likely you're going to see it on the vaginal. The vaginals are critical, but the outside studies are also super important too. What you don't want to hear is, we didn't see your ovaries, but everything looks okay, because there could be something higher up in the pelvis that just didn't show up on the vaginal. So you always want to have a probe put on the outside as well, on the outside of the abdomen, looking at the uterus and the ovaries that way too. And that's also how you do the bladder cancer screening initially. You're getting some more information that way. The pancreas and the kidneys, that cancer screening is all done from the outside with the probe on the abdomen. Sometimes you get really, really pictures of the lining of the uterus on the outside. The vaginal depends on the angle of the probe sending the sound waves to the uterine lining. You can get spurious, what looks like thickened lining on the vaginal, when in fact it's very thin, and the outside picture can resolve that for you really easily. So we want to try and eliminate false findings too. We don't want to tell somebody that something is, oh, uterine lining is thick when it's thin. And so both modalities will help you with that.
I got a message privately. It says, hi, through an MRI, a cystic lesion on my left pubic bone was discovered. Would an ultrasound provide additional information? And she has a biopsy at the end of the month.
No, absolutely not. It can't look at bone at all. So the only thing that can look at bone are MRIs and CT and X-rays. So sound does not look at bone. Just can't go through. Sound waves can't get through the bone. So they're doing the right thing.
Someone also asked to the group, are fibroids any indication of uterine cancer?
Well, fibroids are tumors. And if a fibroid is growing at a very, very rapid rate, statistically, it's still most likely to be a benign fibroid. But if fibroid is growing at an extremely fast rate in someone who's premenopausal, or any fibroid growing after menopause, let's talk about a patient not on any significant hormone replacement, that would be concerning. And a malignant fibroid is called a sarcoma. So there are some times when it's a rate of growth that will, you'll be able to determine if something sarcoma, or sometimes it's the appearance of the fibroid. but rate of growth is very, very important. I often tell women who come in who are postmenopausal, they want to know, did my fibroid shrink? And many fibroids, they don't shrink that much, actually. Majority don't shrink that much, even in menopause, but they're not allowed to grow. So that's really the important question. If someone has fibroids and they're postmenopausal, and even on hormone replacement, the levels are pretty low now. They really shouldn't be growing that much at all. So if somebody's fibroid is growing postmenopausally, that would be a red flag. Most fibroids are benign.
There's a
Go ahead, Carly.
There's a question in the chat that says, can early stage ovarian cancer represent as fatty liver? How does my CHEK2 mutation impact chances of recurrence?
That is too complicated a question for me as far as fatty livers go and that situation. So I would defer that to whoever's taking care of them. And I think as far as, the ovarian cancer situation going, we've talked about is really right now, as far as I'm concerned, the best and only way to catch disease in the ovary early is with a pelvic ultrasound. That's what I would say about that. No matter what somebody's pathogenic mutation is. And even if they don't have a pathogenic mutation, I want to try and obviously spend a lot of time with my patients who have pathogenic mutations. And we talk about prophylactic surgery, and we talk about how often they should come in. And I, as I've said, recommend twice a year, but some people want more. But I'm just as much focused on people who have no pathogenic mutations and have no family histories. Somebody's going to get the family history going. And I don't feel that enough attention is paid to those people.
Luce, you have your hand up.
Yes, thank you. And thank you for doing this. I just finished chemo for ovarian cancer stage 3B. And so I'm about to start olaparib, I think. And so my question is, can you detect as after surgery and debulking as well with this technique as when it's just starting to happen and it's early stage? So I guess what I'm asking is, maybe you've covered this already. Is ultrasound good for recurrence and detecting that more quickly than a CT scan? I apologize if you've already answered this.
I did mention a case where I had seen a recurrence where it was a very non-aggressive cell, so it wasn't really, and it was a very small recurrence, so it wasn't showing up on the PET. But no, the way to go for checking for recurrence and to scan the entire abdomen, where you're really looking at the mesentery of the bowel. A lot of people at this point have had the uterus and ovaries removed, the omentum removed. Looking for disease in the omentum, the ultrasound is not good for that. So absolutely has to be the screening, no question. And I also do believe very, very strongly that's not the place for ultrasound, is for looking necessarily for recurrence, and that's not the place for it. I believe the strong place for it, it's not that it's not used, and we mentioned for people who've had hysterectomies to look at what's called the vaginal cuff, very, very helpful when they're disease-free and just to make sure that everything's okay. But as far as ovarian, no, the standard of care is still always going to be CT, and that's the way it should be. Yeah. It's really going to look at the bowel loops, and in between the bowel loops is what I mean, that tissue there, the mesentery, and have a much better look at the abdominal wall and the abdominal cavity. Sono will not do that, absolutely not. The goal for the sonogram and why to have a pelvic ultrasound is really more to try and catch disease as early as possible. I feel that a lot of women, the first time they get an ultrasound is because they have a symptom. And I'd like to change the approach to when a pelvic ultrasound is done. I want it to be done before anybody ever has a symptom, be it vague or not vague, be it lasting for 4 weeks or lasting for 6 months. I want people to know that the way to catch disease, the best way, pretty much with any cancer for that matter, is when there's no symptoms. So it's a good question, but CT is the way to go.
Thank you.
Yeah.
Sherry, your hand's up.
Yeah, hi, Dr. Schonholz. I had this transvaginal ultrasound in like January, and then I think it didn't show anything, and my CA 125 was not taken. And about 4 months later, I was stage 3C. And I guess
So that would depend a lot on the initial cell. So if it was a slow growing cell, I can't speak about your case specifically, but when it's a slow growing cell, then there's a certain doubling time, and people can kind of look back, and many oncologists might say to somebody, oh, that's been there for X number of so long. Sometimes patients come in and they say this to me, oh, I was told, oh, that was probably there for so many, months or so many years. So a lot depends on that adjective of what was the cell type. So the stage is different. The stage is where did the cells go? And then there's the actual cell type. How aggressive was the cell? So if somebody had a scan, be it MR, CT, sono, and 4 months go by, and then the person presents with some advanced disease, if it was an aggressive cell, like a serous carcinoma coming off from the end of the fallopian tube, these microscopics, then that's a cell that can be very aggressive in a very short period of time. If the pathology revealed a more slow growing cell, one would have to, go back and look at some images and say, was there something there that was interpreted as not being there, but it was there. You're asking an important question.
it's interesting that I didn't know that the follow-up after surgery is CT scans and not transvaginal ultrasounds. That's so interesting.
Yeah, predominantly because you do want to get a look at the entire abdominal cavity. So it's usually used as a way, just as another way, particularly to look at an area called the cul-de-sac, where sometimes disease will collect there. And that's a great place to see recurrence on a sonogram, because the vaginal scan is very close up to that area, and it can see small implants in that area. But to look at the overall abdominal cavity, that would be a CT. Yeah, it's very helpful. And definitely we've seen recurrence in cases where the vaginal sonogram will pick up a recurrence, and then there will be more imaging done after that.
Thank you.
Yeah, welcome.
So there's a couple of questions in the chat, and then I have another one as well. But can ultrasounds be used to track hematomas in my peritoneum? I probably pronounced that wrong. If so, can that tell more than a CT, MRI, et cetera, without a rising CA 125?
Well, so a hematoma is just a collection of blood. So that wouldn't be, a malignancy. That would be typically something post-operative that somebody had a bleed, and certainly sonograms can see that. Classically, why would somebody go for a CT imaging for that? They would go for CT imaging because sometimes then you might have some percutaneous drainage, meaning through the skin, they would introduce a catheter and do a procedure where they would drain it. Sometimes that can be done under ultrasound as well. But as far as a hematoma and increasing CA 125, those would be two very separate situations, because a hematoma is just a collection of blood. Ascites is different. Ascites is fluid that has, when it's malignant ascites, has abnormal cells in it, has cancer cells, and cancer cells are making fluid in the abdomen. So I don't know if they meant hematoma or if they meant that there was, a pocket of ascites that was in the abdomen. And again, I would say an ultrasound is great at finding fluid. So it's an actual excellent study for that. And so if somebody was interested, if there was fluid within the abdomen, there's no question an ultrasound would be great. But at the same time, somebody might be interested in knowing, is there fluid, but is there also cancer implants? And I would say probably the CT again would be the best way to go. My focus is particularly on finding early disease and which is subtle. And the CTs and the MRs are not going to do that for the ovary at this moment in time. So when we're following disease, it's really important to get the holistic approach of the body. Many times the lungs have to be looked into, right? There can be fluid in the lungs or disease in lungs. And so it makes much more sense to do the CT imaging. Absolutely. Some people do MR imaging, but predominantly CT. Really important to do that. We don't want to replace a modality with something that's not going to give as much information as somebody needs. But to diagnose initially at an early stage for ovarian, it's a sono for sure.
And then is there a difference between a pathogenic mutation and a mutation?
Oh, well, that would be something I'd probably would have Jillian have a geneticist come, but there's certainly variants and there's pathogenic mutations and variants. This is the way I explain it to my patients, is that something's not been made quite right with the gene. We all have the same genes. We all with the RCA, we all have, on all of these genes. We don't want the mutation. We don't want them to have the pathogenic mutation. We're not sure we want the variant either, but the variants, I tell people, they're sort of like on a back burner of a stove. And not enough people in the world have cancer associated with that variant. So it's not normal. It hasn't been formed normally, but it's not been associated in enough people, enough cancers to say, is this really going to increase your risk of anything? And so these variants are tracked as more and more people get diagnosed with cancer. If somebody obviously started having more patients had a variant associated with a certain cancer, that variant would then be moved, I tell them, to the front burner. And if it over time, the variant is not associated with cancers, it would get taken off the stove. It's just not relevant. And sometimes that happens. You find out from the company that where you've been tested, the variant is just not of concern any longer. Or no, the variant has morphed into something that is of concern.
The question is, I still had ascites after the surgery in the stomach. Should I get another scan to confirm it's still there?
Well, I mean, again, that's a total question for an oncologist, but my answer would be yes, without knowing anything about anything. I think if, somebody has an abnormal finding, you want to know, is that finding, what do you do about the finding? That's the first thing. And then is more imaging required is the second thing. So just from the question, I would say, obviously the person moving forward, needs more information for sure, which may be accomplished with imaging. I'm not sure what kind of imaging the doctor would want. CT, PET CT, do they want a sono? That's based on the oncologist for sure.
And I have a follow-up question based on something that you said earlier about children of a woman that has had cancer. So personally, I've been in surveillance with mammogram and MRI with contrast every 6 months since I was 25. Should I advocate? What was that?
Breast sonograms as well, because there's dense breasts.
So it is dense breast, but I've never gotten a breast sonogram. And should I advocate for pelvic ultrasound?
So different institutions work different ways. In our practice, if somebody has a dense breast, they are always, with their mammogram, they always get a breast sonogram. Why is that? If you walk out of a mammogram without a breast sonogram at that time, if you're told your mammogram is normal, you haven't actually been told your breast is normal unless you have the sonogram. Cancers on a dense breast mammogram are white and glandular fibrocystic tissue is white. It's like throwing a radioactive snowball on a field of snow, and I told you, you need to find it in about 20 minutes. And you're going to go, why did you throw that on a field of snow? Why didn't you make it darker? And I'll go, okay, I'll make it darker. We'll do a sonogram now because glandular fibrocystic tissue is white on a sonogram and cancers look like a lump of coal. So if you're going to walk out of a mammogram, in our practice, you will not leave without having a breast sonogram. People who are at increased risk of breast cancer, the protocol in our practice is mammo-sono, and I'm talking significant increased risk of breast cancer. 6 months later, breast MRI with gadolinium. It must always be done with gadolinium. Some patients don't want the breast MRI, they can't tolerate it, in which case they get a second look sono, it's called, looking for an interval cancer within 6 months. I'm sorry, and the other question was about the screening.
What about adding a pelvic sonogram to surveillance?
for breast should be screening for pelvic for their ovaries.
Right. Okay.
And I just told you, anybody not at risk for cancer should be screening their ovaries. So your question to me, I think if I saw you would be, do I come once or twice a year would be your question.
Right.
Yeah.
Thank you.
Only once a year, like anybody else.
And iPhone has their hand up.
Oh, it's me, Nancy.
Oh, hi. Nan.
Okay, my question is, you might have answered this already because I was driving and I might have lost a couple of times, but I'm a granulosis patient. I don't know if you're aware of granulosis tumors.
Yeah. No, it's a cell tumors.
Yes. And I just wanted to understand, I know you were saying that ultrasounds are good, you know, for certain types of tumors. I was diagnosed with an ultrasound, but I still go for CT scans. And for some reason, mine are very small. And I currently have 2 of them that they keep saying that are very small, and they've been checking them for 5 years now. But I feel like I have others and they don't see them. And I don't know if this, I'm sorry.
You have others in your word, you have implants you have tumor implants in your body. I'm not sure I'm understanding.
Yes, I feel like I have other tumors in my body and they don't find them on the CT scan. So I want to know if I should ask to get an ultrasound.
Well, I think if you're having CT imaging or you're having PET CT imaging, I don't know if the ultrasound would help or not. It sounds like you're being looked at quite thoroughly. I did mention sometimes the place where we might pick up some small disease is in the cul-de-sac on a vaginal sonogram. And it would be additional imaging. It would not replace, in your case, what you're doing. It would just be done as an additional image where you'd say, all right, I understand this isn't seeing anything. I'm worried there's something in there that's not being seen. Would it be okay to do a sonogram as well? It's a non-invasive test. It may not show anything else. It might show something. So it would just be to put the question out there. It really depends, obviously. The case is very, very specific, and it would really depend on the previous imaging and where disease was found, and would the ultrasound be of any help? That's all. And it might not be. Yeah, I feel like with post-operative cases, the clear vision for me of getting ultrasounds into the general population is, again, for asymptomatic people to screen to pick up very early disease. Can it be helpful in cases where there's an implant and there's disease that has progressed elsewhere? If this patient wants additional imaging beyond a CT, certainly an oncologist may say it's okay to try and get an ultrasound to take a look, but sounds like there's no question CT imaging is the way to go.
Okay. Thank you.
Yeah, but I would always advocate for myself, and as far as if you wanted another modality just to see if it could do something, it might not, but you want to get the best modality done for what the problem is.
I mean, it's just so funny that you mentioned the ultrasound, and that's how I was diagnosed finally, and so for me now to go through CT scans, and I still feel like this is my 5th recurrence. So it's like, and they know it's there, but I feel like I feel like there's more and they're not seeing it and they're just concentrating. Yeah.
I totally hear you. And I think in your case specifically, because every case is different, you have this trust in the ultrasound because it found your disease initially. And you feel strongly there may be something going on that it's not seeing, and there's certainly be no harm in doing it. That's for sure.
Okay.
It's not,
Thank you.
There's no IV contrast, there's no radiation. You could look, you could look a number of times to try and find it if necessary.
All right.
And
Thank
give
you.
you some mind. I think it's important to do.
Okay.
Looks like there's one final question. There's 2. One is a PET scan better than a CT scan?
Well, I don't do PET or CT. So as far as why would one be better than the other, they accomplish different things. And clearly when some people are looking for extent of disease, particularly initially during an initial diagnosis, that's used in some cases. And sometimes it's just a CT, and I would have to honestly defer to the oncologist to decide, which one they would want.
And my assumption is this, if you're going to say the same answer in terms of the oncologist, but the person wrote, for someone who's had all preventative surgeries, currently asymptomatic, what's the best scan to use when screening for possible PPC?
When I'm a big proponent of still looking for disease in people who have had prophylactic surgery, just in case primary peritoneal carcinoma, does present, and it's not a common cancer, thank goodness. But clearly the ultrasound finds fluid. It's one of the things that it does really, really well. And I would say that that would be an excellent way to look for primary peritoneal cancer in individuals who have had prophylactic surgery. Yeah. It sees fluid very easily. Yeah. And not all cases have an elevated CA-125, but that'd be also something they would be tracking with their gynecologist, tracking blood work as well, which can be non-specifically elevated, but I think it is important to keep one's eye on that. We see a lot of people with pelvic fluid that's benign. I followed the cases up in a matter of 4 weeks, and then they're unchanged, the fluid, or the fluid resorbs. And in cases where the fluid does not resorb, I bring them back in another 4 weeks. And because if it's going to be primary peritoneal, that fluid's going to increase and change over time, and it's not going to take a long time. So it makes you more comfortable when you've done a couple of serial sonograms for fluid. I treat fluid very, very seriously, because we never want to miss a case of primary peritoneal carcinoma.
Well, I think, it is 1 o'clock. I want to be mindful of your time. I just saw that Joan wrote, this is incredibly informative, and that you are forthright and calm, and that she appreciates meeting you. And I think that speaks on behalf of all of us.
If I can help anybody on the panel, I'm available. And if somebody wants to reach out to me personally, Jillian, you can share my office number, and I would be more than happy to speak to them about their individual cases, if it would be helpful.
Thank you.
Always
Thank
deferring
you
back to
very
their oncologist, but if I be helpful in some way, I would love to do that.
much.
It's been a pleasure. I
you.
hope we can just spread the word and catch disease as early as possible. That's my goal.
Thank you. Thank you so very much, everyone.
Diane,
Enjoy
thank
the
you.
rest of the day. And we'll be back next week. Will be a regular general talk group. So thank you again, everybody.
Your regular time. Okay.
Bye.
Thank you.
Bye, everybody.
Bye-bye.
Bye.
Take care. Bye-bye.